Well, welcome to Thursday morning, everyone. Hope we're all excited for our talk today. I'm gonna get my screen shared. Hopefully that's gonna work out, and then we're gonna get into the whole presentation. I'm gonna get a nod that we're seeing what I'm seeing, and we are in presentation mode. Fantastic. Okay. So yeah, this is part 2 of 3. So we have the previous one, the first training that we did was all about LGBTQ plus demographic information. We are going to be moving into, for our next one, it'll be about suicide prevention and kind of how we've been addressing suicidality within our queer populations across North Dakota. Today, we'll be focusing on outcomes of our queer population as well as ways to mitigate some of the negative outcomes we see specifically within healthcare structures. So I'm your speaker. If you aren't here for the first one, some of this will be new to you. If you are here for the first one, you know who I am, and you'll have to sit through me talking about me again for a little bit. So, my name's Faye. I'm a lifelong North Dakotan. I grew up in the Fargo area. I am a queer woman, and I experienced a lot of the, let's say, negative outcomes that we're going to be talking about today. I fell through the cracks of the system, whether that be family support, social support, school systems, healthcare, basically in any way that you could be failed by systems. I was when I was younger, and I really try to make sure that we are doing better for our kids today. When we think about this work, we often focus on things like allyship or sometimes more like diversity, equity, inclusion work. And I think that's important. But when I think about it as a healthcare individual, I think about safety. How do we keep people safe? That's my number one priority within all these conversations in that work. I started a Harbor Health Clinic, so I have a lot of experience with kind of clinical background. I myself am not a doctor. I don't practice with mental or physical health, but I do a lot more of the administration, nonprofit stuff. I do a lot more with that research and grant writing. That tends to be my intersection. I'm also the data expert for our LGBTQ plus outcomes, mostly because I'm kind of the reason we have that data. I've been submitting questions for the Youth Risk Behavior Survey, the Behavioral Risk Factor Surveillance Systems, and basically everyone who has data, I tell them to give it to me on our queer population. So I'm a repository of a lot of that stuff. And I say I'm the state expert on it because no one's challenged me yet, and I would welcome the challenge. Like, if you want to learn more about this stuff and challenge me, please do. I would love help in this work. I also work as the LGBTQ plus care coordinator for Canopy Medical Clinic. So again, I have a lot of clinical experience. I know how clinics work. I've done a lot of community research, as I already talked about, and I've been providing trainings like this for 10 years. So I have a wealth of knowledge for providing education like this. And then finally, I'm an award-winning activist, and I do a lot with suicide prevention. We'll be talking about queer populations and healthcare today, but suicide prevention is my number one focus within this work. It's something that no matter what I'm doing, I'm trying to reduce suicidality, not just for queer populations, but for anyone, it's a higher likelihood of happening to demographically. That could be Indigenous, rural, farmers, veterans, police, first responders, queer populations. Like, I'm there to make sure people have hope in the state. My specialty happens to be with LG plus individuals, but I do everything that I can. That is my work and who I am. So the first thing we're going to talk about is just that outcome data in particular, or our goals and then outcome data. Our goals today are going to be accurate view of our LG plus outcomes, barriers patients have to access healthcare, and then process improvement in key tools for service. So this training is going to be a huge benefit to folks who work in our healthcare systems, either administratively, more holistically understanding the systems together, like public health, or doctors in particular, and understanding how patient care might work on that level. So there's a lot of benefits to this training wherever you happen to slot into healthcare. So to actually talk about data, like I was promising, we're going to be talking about the Youth Risk Behavior Survey. The good news is that we do have data on adults for our LG plus adult population. My light's flickering in a scary way. I'm sure I'm fine. So we have that data, but I only got it like 2 weeks ago, and I've had other conferences, and I just have not had time to get to it yet. But we do have some preliminary data on LGBTQ plus adults for the first time in our state in 10 years. Looking through it kind of casually, it kind of seems the same. You get the general same outcomes for patient populations for discrepancy in care, discrepancy in how they're feeling within mental health. So as we look at these youth and how they are doing, I want you to think about two things. One, if you don't serve youth, these are your future adults. These are the experiences that adults in our state probably had growing up. So even if youth aren't your population, these are some experiences adults probably do have. The other thing is that our data set for trans populations is going to be less valid only in the sense that it's harder to collect data on trans individuals being a lower population within the community. When we think of demographics, trans individuals are usually about 1 in 50. Or about 2% of individuals, and that's not a lot. So if we're surveying 100 people, we're lucky to get 2 trans individuals in that survey. If we're surveying 2,000 to 10,000, we're still at best getting maybe 200 trans folks in those surveys, and we don't often do 10,000 people surveys in North Dakota. So the data for trans individuals is lower, but it's just so hard to get large population demographics from trans people. So when we look at that, I want you to consider the trans data to be suggestive, but for our lesbian, gay, and bi data, this has been pretty consistent across a long time with a big population pool. So we can imagine it's pretty accurate for our experiences of both our youth and future adults. So the first thing I want to talk about is safety, and that's bullying. We have broken them up between straight, LGB, and trans for how individuals are impacted for kind of that lens of safety. And you can see for our straight youth, bullying happens in school for about 36% of them. It happens online for about 25% of them, and they've experienced sexual violence. About 8% of our straight youth have experienced that. When you just kind of look over to how the screen's presenting itself for our LGB and trans youth, you can see that there's a large discrepancy in bullying and outcomes here. And you can see that for sexual violence, at least for our trans community, it's actually significantly higher than for straight and LGB youth. When we think about bullying, and if you understand adverse childhood experiences or the ways that this can really impact all of our sectors and systems, when youth are bullied, they can often feel unsafe. And when they feel unsafe, they can sometimes reach out about it, and maybe their teacher will say, well, suck it up, or their teacher won't have time for it, or they will just go, just don't talk to those kids anymore or avoid them. They sometimes won't get adequate ways to address the abuse they're experiencing from adults. Those could be parents or school counselors or teachers. And when they have problems like bullying and they try to resolve or talk about them without getting solutions and they're shut down, they're less likely to trust any sort of what we call authority figure. And that could be a doctor, that could be a therapist. When you feel like adults aren't there to help you, it really sets the stage at a young age in your life that you don't get help. Something I'll be talking about throughout these slides about data and outcomes is that I really want you to think about them in terms of trust and safety, because bullying, I think, is one area where you start to really lose trust that you can even be safe. And one of the reasons I think that we have higher bullying for our queer populations, and this isn't really, it's not from a data perspective, it's just looking at the data and having a lot of experience with this. And I try to denote when I'm telling you that, as opposed to it being very sound with the data. I believe what ends up happening here is that our LGB, our trans, our queer youth, they feel less likely that they will get help when talking to adults, especially if they're bullied for being gay or trans. And I think the reason we see higher sexual violence among LGBT individuals and trans individuals is because they're less secure, safe, or trust talking to adults when problems do come up. And I think for our straight youth, while situations can occur, they're more likely to talk to adults and get those resolved before they become actual problems. These are some ways to think about the data as we kind of go through this. For family social capital, we can see something that is really alarming. I've broken these down into like 3 words: eat with family, talk to family, hurt by family. The actual questions are a lot bigger, but just to condense and summarize this data a little bit better. When we look at eat with family, this is like spend a meal with your family at night, I think is the question that gets asked, but you can see for our straight youth, it's pretty frequent. And this is middle school data, so these kids probably aren't eating, like they're not like, I don't know, going to Denny's. These 7th graders aren't just like driving to Denny's for their dinner. Like if they're not eating with their family, it's something's going on. So 79% are eating with their family, I think regularly is what the question asked, but then it goes down to 59% and then about 50% for our trans youth. And when I think about this, I think about a lot of things. I think about how safe they feel with their family, how well taken care of they are by their family, how much they trust their family, and how much social cohesion they have in that family unit for social capital, as we'd call it. And it's just less. And when we look at this, and I'm going to talk about the discrepancies a lot and how much lower or worse it is for queer populations, I do want you to keep in mind it's not like 0, right? We are still seeing a lot of these kids having decent lives, decent outcomes, decent family relationships. So as we talk about the negative, also keep that in mind. It does suck for some of these youth, but it's not. A lot of them are still doing pretty well, and it's important to keep that in focus. In terms of talking to family, the actual question is, would you talk to your parents if you're feeling sad, empty, hopeless, or angry? So basically, if a kid's having these big emotions, how likely are they to go to their parent to resolve those issues? And a lot of kids don't talk to their parents. By middle school, they're kind of figuring themselves out and want to be like little adults, and they don't want to like talk to their parents about anything. That's a common complaint with any parent in developmental psychology. It's just kids just stop talking to you, and it's really annoying. But when we're looking at straight youth for that, it's about 20% still talk to their family. But when we look at LGBT or trans youth, it drops down to 10%. So only 1 in 10 of these kids are actually talking to their parents when bad things happen to them. But sometimes those bad things are sexual violence, and they're more likely to occur. So it just becomes this thing where there is a cascading effect where they lose social support across several systems, making things a little bit more scary in every way things can fail. When we look at high school students, this drops even further, and only about 5% of trans students 1 in 20 will talk to their parents if something bad's happening in their life. I will say that about half of them still talk to folks within the school system, like adults in the school system. And while the data didn't ask about this, I assume the same is true about doctors too. They're more likely to talk to doctors or other adults in their life that they maybe have more trust with. When we look at hurt by family, we can also see that going much higher for our LGBTQ populations. And that question says kind of put down by parents is the actual question. But one of the ways I want you to think about this is these are these kids' perception. And I think that parents have a different perception of what they say and its impact on their kids than the kids do. So I think there's a lot of parents who maybe don't feel like they're putting their child down or don't feel like they're saying something that is hurting their child, whereas their child will take it in a different way. So I don't want you to look at that and think that a lot of queer youth have terribly abusive parents that are hurting their kids. I think it's a much more nuanced and complex situation than that. And I think that these kids are just feeling hurt and isolated and not able to talk about it. It's going to be different for everyone, but that's just some way to consider and think about that data. When we talk about mental health, I think it's pretty obvious that if these kids are getting bullied, not eating with their family, feeling put down by their family, and not talking about the problems they're having, they're going to have worse mental health. And there's a lot of questions that talk about mental health, but it's all the same. Our LGBT plus individuals have worse mental health. It's maybe worth saying that it's not a causation situation where queer individuals don't intrinsically have worse mental health. There's a lot of different theories, whether it be minority stress theory or different ways of looking at queer populations, where what we find is that when queer individuals are able to eat, be socially included, have acceptance from their parents, and wherever they may exist, it could be a job, college, school, wherever, if all of that's going good, they do as well as anyone else in the general population. So we often see that there tends to be a lot of overlap with depression, anxiety, and queer identity, but that's largely explainable due to the ways sometimes queer individuals can be treated within our culture. When we look at substance abuse, this is kind of a bigger problem with our queer youth in general, but substance abuse can be a lot of different things. I've broken it down into smoking, alcohol, and cannabis. I even color-coded it, I guess, at some point. I realized I did that much later, but smoking is obviously gray. Alcohol, I chose a light blue and then green for cannabis. Sometimes you work with data so much, you just kind of want to be cute sometimes with it and just like make it a little more colorful or play with it. But one of the biggest discrepancies I found in the data was that trans youth were 15 times more likely to start smoking at a young age. This is kind of due to the data being such a smaller part for our trans population, but still, when you look across the data, you see similar outcomes. You see higher likelihood of smoking, cannabis, also prescription use drugs. Every way people can abuse substances, queer youth are doing it more at a younger age and more frequently. And when we understand why youth maybe try drugs or try substances in this case, it can make sense because they're coping with these big feelings they're not talking to anyone about. If they don't feel like they have adults they can be safe with, if they don't feel like they can talk about big things like depression and suicidality or even sexual abuse, and they're sitting with that, that is not a feeling you can sit with. That's not a feeling you can just be okay with. And sometimes the way kids cope with this is they turn to drinking or smoking. And one of the problems that we tend to see here, and I don't think this is really revealed in our systems, is that when these kids are caught, and let's say they're caught smoking, they have smokes on their backpack or vaping in any kind of way, the reaction we typically get from those kids is, oh, I'm just doing it to fit in, or I just thought it was cool, because that's such an easier thing to tell a parent than to tell them that you're suicidal or depressed. And I think a lot of kids deflect with the easiest explanations and not actually get into the really deep-rooted causes for why they're pursuing this. And this is kind of just me. I don't have a strong data backing for this, but I think that some of our data can be a little skewed because we're looking at sometimes the surface level of what these kids are telling parents or us about why they're using substances, and not necessarily understanding them as coping mechanisms for depression or anxiety or suicidality. I wish there was more research on that, and I'd love to find more on it, but I think that that could be a thing that's happening, and that's just more from personal experience and knowing folks who've grown up with queer identity. When we look at this all together, it forms this picture of suicidality. When I talk about suicide, and when I'll talk about it much more in my next presentation next month, suicidality is multifactorial. And if anyone here has any experience with suicidality within treatment or even anything like that, you know that. You can't, it's never one thing. And I think a lot of folks like to think, if a queer individual has tried to take their own life, it's because they are trans or gay in the culture we live in. But there's a lot of things going on. There can be bullying that's not necessarily related to queer identity. There can be, they don't feel like they belong at home, so they have that isolation, like very classic Durkheim study for suicide. But what we understand suicide to be is a lot of components of both protective and risk factors. And what we have for queer individuals is a lot more likelihood of having a lot more risk factors, because those can be adverse childhood experiences, and those can be multiple adverse childhood experiences. So the suicidality is very high within our queer populations. But I will say one thing to be very clear about this. When I look at this chart that you're looking at right now, I think that every single bar here is terrifying. I think that our cisgender youth, our straight youth, our not gay or trans youth, over 20% of them are seriously considering suicide. If we look at the population in North Dakota in particular, in our student population, and you add this all together, we're looking at something like 30,000 students in North Dakota seriously considering suicide. That is the reason I do the work that I do. That is the reason I'm a suicide prevention advocate, and the reason I spend and have dedicated my life to doing work like this is because that is unacceptable to me. I am a person, I'm a suicide survivor. I spent most of my young adult life thinking about suicide, and I don't remember a time when I was younger that I didn't. I don't know where it even came from because it was always part of my identity, this idea that I didn't want to be here anymore. And it could have been queer identity, it could have been my home environment and parent, it was everything added together. But I know what that's like. And when we think about healthcare goals, and we think about patients entering our room, when we think about trying to get them to be more stable or healthy, and they don't think they're going to be here in another year, we have different goals then. And it's harder for us to reach someone who doesn't think they're going to be here next year. It's not impossible. There's a lot of ways to do it, but sometimes we don't have the same conversations when we're trying to talk to someone about their healthcare needs when they maybe don't think they're going to be here anymore. So suicidality is a big problem. It is a difficult problem, and it is, in some ways, the good news is, since it's multifactorial, everything that we do does impact it. We don't ever have to focus on just suicidality, and in some ways we shouldn't. We can focus on all the component parts that add up into it. And that could be housing security, that could be making sure kids eat, that could be mental health support anywhere, that could just be a affirming adult that lets these kids feel safe for a moment. Everything we do reduces suicidality. So we don't have to worry about these big bars and these big numbers. We can take it any way that we want to, in any discipline that we have, because it all matters. So the good news is for our queer youth that you can dramatically reduce suicidality by being an affirming adult. And this is Trevor Project research into it. They did it twice. So it's pretty strong for the data, and it also just kind of passes the vibe test because, like, of course, if these kids have someone they can talk to and feel safe to talk to, they're going to do better. And when we think about this, it's important not to kind of pigeonhole that queer identity into, well, this person can talk to me about being gay or trans, they're going to do better. I think that's true. But being gay and trans is one aspect of these kids' life. There are so many more aspects to it that they're also not talking to us about because they're afraid to. When you can get a kid or adult to open up and talk to you, have serious conversations about their needs, concerns, and fears, you can finally address them and they will do better. So for a lot of these individuals, the queer identity can be a component or a stressor for them, but it's often not the only thing going on in their life. And when we can get them to trust us and open up to us, we're going to be able to learn a lot more about them and a lot more about the specific ways we can treat or help them. So just that's the impact you can have as an individual, is that. So we're going to move into, well, I guess the last thing here is the key topic is understanding trust and safety. I think a lot of professionals in healthcare don't understand that their patients might not trust them. And if they don't trust you, nothing you say matters. You can be the best doctor in the world. You can look at their charts and figure out they absolutely need this medication. But if they don't trust you, they aren't going to follow your directions. And if they don't feel safe with you, they're not going to come back. If you're not establishing that with your patients, it really doesn't matter how good of a doctor you are because they're not going to listen. And it's really important that we understand how afraid patients can be when they come to us and that we have to address these, not just for queer populations, but there's a lot of people who've experienced different levels of medical abuse where it's harder to reach them. And it's important just to have intentionality in those spaces, just to make sure that you are listening to your patients, that you are listening to the needs that they might have. So we're going to go into systems right now, and this is where we're actually going to invite a little bit of dialogue. Uh, I want you to think to yourself, and I don't know exactly where you intersect in our systems right now, but I want you to imagine a young trans woman. Let's say she's 20, and she is going through the healthcare setting. Let's say she has some illness or something like that where she wants to get that checked out. She has the flu. She wants to go in and get some kind of medication for that. From the start of her journey where she goes, where do I go to get a checkup? Or let's say she just wants to do a wellness check would make more sense. From the start of her journey for wanting to get a wellness check, wanting to go in and maybe get a physical, to actually talking to a doctor, kind of figuring out what's going on, figuring out what her health concerns are, then leaving that circumstance, what are some areas where we might lose that patient? What are some areas in which that person might not come in, might not show up, might not come back, or might not listen to our care? Where are some areas that we might lose them? This is just kind of a critical thinking exercise. So think that to yourself for a second. I'm going to be back. I'm just going to get my phone real quick so I have a time. There's two parts to this exercise. So if you don't come up with anything now, I'll give you more help and then I'll give you more things you can come up with. But in any way you can think about this, where might you lose a patient?
Is that a rhetorical question or
No,
yes?
you're invited to just talk.
Okay, so I'm a psychiatrist. I used to be the medical director for the Department of Human Services many years ago, and now I'm with the med school. I think at every possible intersection along the way, you can lose people. Like you talked about for trust, if there's kind of a learned helplessness paradigm where it doesn't even matter for you to step forward, it's not going to happen. Or if you're continually disappointed at every intersection of judgment or recommendations, you lose people.
Yeah, absolutely. I think that's a perfect answer, and you're thinking about it holistically. So, I mean, you seem like you have quite a background to know this stuff, so that is good. So here's my prompts is these are places you can think about losing patients. You can lose them on your website, in your lobby, in your paperwork, in your office, in your systems, and in your outpatient. So what might it look like losing a patient in the website? How might you lose a patient in the lobby? How might you lose a patient in paperwork? So this is again inviting you to think about that and offer where might you lose an LGBTQ plus person in these places, and why would that occur? And you can just unmute yourself since we only have 8 folks here. I don't think it'll be a cacophony of sound or anything. We're adults, we can keep order, right?
I
I think
think part of it is just not being inclusive, like not including them in your paperwork, not being inviting to your lobby, not being inviting to your website. So just not being inclusive.
What are some ways you feel that you could increase that in those environments?
Well, one thing we did in our paperwork is we put like preferred pronouns and preferred name
Mhm.
on our paperwork. So I feel like that's one way.
Absolutely.
think languages and images.
Yeah. If they can see themselves, represented somewhere, it's more likely to get them to go there. Colleges are really good at that. If you ever look at college advertisement, I work with school administrators a lot. Anyone else have anything that they would think about ways to maybe lose a patient in the office? When I say systems, by the way, I mean like health management systems or things like of that nature. All
I
right, I'm
think
gonna let you.
just
Oh, go ahead.
just the things we take for granted, utilizing the restrooms, other places that have certain labels that don't fit with the person's identity.
Yeah, that absolutely. One of the things I like to educate folks on within these parameters, and I'm going to kind of give you some baseline answers for this, is that a lot of times people would like a definitive answer on the paper, and that would be, I do this, and that's the perfect best answer, and I get the perfect best outcomes. And I want you to understand that you can never have that because every healthcare system is going to be a little bit different. If it's a hospital or a clinic, if it's private or not, depending on the doctors you have there or the location or the community, every single place is going to be different. And what I try to educate on is not answers per se, but the ways to be intentional about the spaces that you create. So when we look at, let me get my stuff closed and opened. Okay. So when we look at website lobby paperwork, these are some things you've talked about and what I consider. Are there any indicators that you're LGBTQ plus affirming on your website? A lot of websites are completely neutral and as sterile as hospitals tend to be, but queer individuals are always monitoring safety. If they don't see anything that includes them or talks about them in any way, they self-exclude themselves because they feel like they aren't supposed to go there. Or what will happen is you will have someone who's maybe a gay man or a lesbian who will use your healthcare systems, but they will self-select, not telling you a thing about their sexuality. And that means you are missing a lot of important demographic information that is relevant to their health, especially sexual health. So if you don't have something that invites this, this is probably not information that you're going to get unless you really build trust with the patient. And when we think about it from health care goals and outcomes, we need to know that information. Like the health risk that a trans or a queer individual has is vastly different than someone who might be straight for a lot of different things we can consider. So the more that we can prompt that and the more that we can collect that and create trust to get that, the better health outcomes we're going to have with our patients. When we're thinking about lobby, negative or positive representation, I think you all kind of got this. That's with bathrooms. That could be also with even having any kind of iconography or like a magazine, like Out magazine is like a popular queer magazine in the lobby. But it's also looking at things that could be negative. Like you don't think about having a news station on in the background or on the television. But in our current climate, there's a lot of news stations that can cover trans things in a very biased or unfriendly way, where if a patient's sitting in a lobby and hears that, it's not going to go well for them. Other considerations are thinking about trans individuals who may have different legal names and their preferred names, who may have different gendered names that are in their chart than how they are presenting. Imagine if someone like me is in the lobby and someone says, you know, Frank, we're ready for you, and I'm the one that has to get up and go there. Like that could be something where maybe I feel uncomfortable with someone in that lobby, and because of that, I don't get up. I just miss that. And they're like, oh, okay, I guess Frank left, and then they don't actually see me. I don't think that's happening like every day or anything, but these are the small considerations that can occur where if we're not thinking about patient safety, if we're not thinking about it in a holistic way, those are the little problems that can happen. And when we look at losing trust, it's really hard to earn it back within our queer population because there's a lot that can go into that, but a lot of times with our trauma, we can see things very much in black and white, where things are all safe or not safe at all. When we look at paperwork, this is mentioned, so I'm glad about that, and you're doing it perfectly with preferred name on the forms. When you include it, preferred name and pronouns and stuff like that on forms, it makes trans individuals feel more likely that they can talk about themselves as part of care. They can put themselves down there somewhere. But you do have to look out for your systems, which will be coming up in a second, because you can have that on your forms, but then none of your nurses or doctors actually look at the preferred name that's in your systems. Some systems are getting better at this, and I think our electronic health records and all of that they're starting to finally catch up and allow preferred name to exist on the face sheet of patients. But most like the smaller systems right now, you have to dig for it. Or you have to work around it and figure out a way to like do patient alerts just for their name. So there's different ways you can work on it, but make sure if it's on the paperwork, it's not just there for fun, you're doing something with it. In office, there's a lot of ways to lose a patient there, and that can be stigma or judgment about the patient, especially if they're talking about sexual health or their own identity, where you are making assumptions about it or disregarding it completely. I think the bigger way that can play out is individuals who, they don't really care a person's trans, but they don't think about it either. And that could be someone who, I'll just kind of use the name Frank again. Let's say I'm like sitting in the room and they just kind of go in, it's like, okay, Frank, what's going on with your health today? And they just, notice there's maybe a discrepancy between that name and how I appear. Though I guess like some women are named Frank, now that I think about it, or Frankie. So anyways, those are things that can play out like that, where if you're not acknowledging the patient in front of you, that can lead to them not necessarily trusting you. One of the ways people shut down though in those conversations is they, become agreeable. Okay, yeah, no, yep, yeah, absolutely, I'll do that. And then they leave and they never come back. There's a lot of ways to handle that, and I have a whole module on Office in particular, so we'll get into that later. In the systems, I really just ask, what is our system to make sure that we are compliant and make sure that we are getting good health outcomes? And that is, yes, our website's good. Yes, our lobby's good. Our paperwork's good. Our office is good. How are we guaranteeing this stays good? And that is making sure you have good communication networks. So your doctors, depending on where you are, have like 10 minutes a patient. Like they cannot keep all of this information on the top of their head. So you really do need to depend on your reception people, your intake specialist, and your nurses to make sure somewhere in that system, the communication is a good through line so doctors know what to expect and know how to have those conversations. And the last thing I will say, and this is probably the thing I see missed the most in healthcare, is your facility is amazing, but then you make a referral to a place that isn't, because some places aren't. And then the patient goes there and has a terrible experience. And that isn't just they come back and go, oh, that place sucked. Where else you got, doc? They stop trusting you too, because you sent them into a place that wasn't safe. I don't think that we're dealing with a ton of scary places necessarily in North Dakota. Some are more than others, but make sure that if you are referring someone, you do think about where you're referring them to. There are places that have reputations for not being safe for queer individuals that I on a one-to-one basis will tell folks maybe don't refer someone there. I don't want to make any kind of public display of shame for a place, but realistically, I do know of some places where I've heard a lot of bad stories about how queer individuals are treated there. So make sure that you are at least checking in with the places you refer to make sure that they are at least as doing a good job as you are on these things, that they at least care about them and have some mechanism. And this is something that you develop relationships over years or decades, so it becomes known the more you work on this. It doesn't have to be a thing that's a ton of work forever. So what I often say with my keynote on this one is, why are we in healthcare? And the reason I ask that question is because right now we have a lot of, let's say, cultural hesitancy to treat trans individuals or queer individuals with, let's say, respect. There are a lot of folks who would like to, for either religious or conscientious reasons, not refer to a trans individual as how they would prefer to be referred to as, or to refuse certain kinds of medications for these demographics. In some cases, still being decided if that's a legal thing to do or not. But I try to talk about what shared goals might be. And if someone does have whatever kind of, let's say, hostility or hesitation with queer populations, I talk about why are we in healthcare? What are our goals in healthcare? Because to me, it's patient outcomes, it's patient safety. And I don't really see a situation where you are misgendering a patient who does not then feel safe with you, nor do they feel safe coming back to you or getting care from you as meeting the goals of why you're in healthcare. And I think that when we are adults in this and practicing it and trying to make sure that we are getting good outcomes, we have to be patient focused. And it's strange to me, people would not want to be patient focused in that work. This is the way I kind of conceptualize it and try to at least bridge some barriers between folks with some cultural hesitancy about these things. But it's just ultimately, we all just want patients to do better. Like, we want them to meet their health goals. We want them to have a good quality of life. And I think there are specific ways we do this for queer populations that involves listening to them and making them feel safe. So how does a actual visit look like? So one of the things that I find very helpful, it's called the 5 keys of service. This is more for like your doctors or folks who are actually in office. And this was developed for survivors, trans survivors of sexual assault. And it was developed to basically make sure that this care was done in the safest way possible because you're dealing with a population that has such a high level of trauma and distrust in systems. So it was developed in 2014, I want to say, and I haven't seen something better since. And I'm someone who keeps on looking up different guidelines on these things to find the best stuff. But this is just my favorite one that's ever been made. The first lesson in the 5 keys of service, an actual like research thing is going to pop up on the bottom right when I'm done with this. But the first one is don't categorize user clients terms. Now, the reason this is important is because for a few different things. You might have someone who is what we consider demographically a trans woman, but they might not identify as trans at all. They might not like that word. And if you sit down and start saying, oh, if you're a trans woman, you're going to have a higher risk of HIV or something like that. If you are, engaging in sex work, that can be a conversation. They really might not like that word. That might not be how they describe or understand themselves. It's important to listen to how they talk about themselves and conceptualize themselves. But another way this plays out isn't even necessarily with, let's say, queer populations. There are a lot of men who identify as straight and will always identify as straight, and they also have sex with other men. And maybe they're married, maybe we consider them bisexual, maybe there's a lot of different things going on. But if we make assumptions about our patients based on how they're identifying, whether that be straight or gay, we are sometimes closing ourselves off to asking maybe more important questions about who are some of your sexual partners, as opposed to just assuming that all of your men that are coming in who say they're straight are only having sex with women. There are a lot of ways that can play out. And if you ever saw the movie Brokeback Mountain, like I actually saw it for the first time a year or two ago, that's actually an incredibly good example because one of the characters in there never throughout the course of the movie identifies as being gay because of experiences he had growing up where a gay man was violently murdered. Even though we probably would consider him to be gay, maybe bisexual, he does not want that label applied to him ever. And if we don't know that about his sexual history, we're not figuring out things about STIs or possible risk of HIV or AIDS. It's important that we really listen to our client and not make assumptions based on the labels that they're giving us for all kinds of health reasons. It's very important. So don't categorize user clients terms. Whatever they're referring to themselves, you can, like, I guess to go back a second on that, even if they were having sex with men, you wouldn't then say, oh, you're a gay man or bi man. It's just understanding the ways people use labels are going to be different, but continue to refer to them as straight. Like, if they're not calling themselves gay, you shouldn't. Know why you're asking and explain why. Now, this one is incredibly important for anyone that has any kind of trust deficiency in systems. And that is a lot of times doctors don't explain much. And they'll be like, okay, we're going to order these 3 tests or, something like that. And they're like, okay, the person's going to get those tests. The lab results are going to come back for me. I'm going to see if they have elevated results here. And maybe they have, something going on with this. But when we're looking at a queer population, And let's say you're talking to a trans individual and you're saying, hey, have you had, bottom surgery before? That question can really put someone on guard. And they don't know why you're necessarily asking it, and they don't know if it's even medically relevant to what's going on, and it might not be. What I tell people is you can ask any question that you want to. As a doctor, as a healthcare provider, ask anything that you need to, but explain why you're asking it. You might be asking about surgery, about bottom surgery, because a trans individual is more likely to have that than someone who's not. And you might be asking about it because you're thinking about a medication that's not safe if someone's had surgery in the last couple of weeks or might be having surgery in a couple of months. Maybe that's why you're asking that question. And then you can explain to them, are you thinking about having any surgeries? Because I think this medication would be really good for you, but it's something that's not safe if you are thinking about surgery. If you can explain why you're asking a question to a patient, it will let them be a little more, off guard and be like, okay, yeah, that makes sense. Well, no, I don't have that surgery, or I'm not considering surgery, or maybe they will. But whatever you're doing and whatever you're asking about the patient, make sure you can explain why you are doing that. And if you can't explain it, then you probably shouldn't be asking. If you can't explain the reason you want that information, maybe you don't actually need it. And that will help you curb different ways we might communicate that makes people feel less safe. Considering the whole person is important. And I talked about this with the multifactorial nature of suicide, but a lot of times a person will come in who might be trans or gay, and you might really think, okay, this is a trans person. I know demographically that they're more likely to experience abuse at home. They're more likely to have substance abuse problems. They're more likely to have suicidality. So when they come in here, I'm going to talk to them about if they have been smoking. I'm going to talk about tobacco cessation. I'm going to talk to them about sexual health and condom use. I'm going to talk to them about 988 and our suicide prevention numbers, and that's a good way to treat this patient. I also told you that a lot of our patients, or sorry, I say patients a lot of our queer demographic isn't doing that bad either. Like, I mean, we do see heightened results, but still we are looking at a lot of them that aren't have suicidal ideation. We're looking at a lot of them that do eat with their family. There is even some that talk to their family or have good relationships. They could be coming in because of just regular health issues. They could be sad or depressed, not because of trans and culture, but because they broke up with a partner and people are going to be depressed about that. It's really important that when you have that trans individual, you can consider there might be these other questions to have, but you also have to take into account what else is going on in their life. One way we see this play out is in endocrinology in particular, and that is the research on this is actually a little bit mixed, but we generally consider estrogen to be something that makes blood clotting more likely. And with trans individuals and trans women in particular, we talk about deep vein thrombosis as a particular risk factor when taking estrogen. And it's also a risk factor with birth control and things like that. But if you have a trans individual who has a blood clot of some kind, you might look at that and go, well, we need to stop the estrogen because that's probably causing this. It might be. There might also be underlying conditions that are causing that as well. And we actually had a patient that had like a very rare blood clotting disorder. I don't even know what it was. Like they had to see an endocrinologist and they had to figure that out. But if we didn't consider alternatives and just stop the estrogen, we never would have found out they had that underlying condition. If we made that assumption that led that care, there are other compounding factors we would have missed. So when you are dealing with a trans patient or a queer individual, just make sure that you are considering them like you would any other patient as well. That the queer identity might inform some of this or might inform some of the risk factors to talk about, but it doesn't explain people as a whole. Everyone's going to be a little bit complex or diverse with how they experience their life. The other thing here is partnering with your client, especially with trans clients, but a lot of times doctors don't quite know what to do with their queer population when they're looking at queer folks who maybe are struggling with mental health, struggling with support, or one of the ways this plays out that I always talk about is you could have a trans woman who has been a victim of sexual or survivor of sexual assault. They could be going to the Rape and Abuse Crisis Center and you could be sitting down with them and talking to them. And then you just suddenly think like, well, I should put this person in a support group with other survivors, but what if she isn't a safe person for some of the other survivors in that group? And what if there is intergroup conflict because of that that doesn't actually help anyone in that circle? What do I do about that? And that can be a tough question. But the first question you should ask is, hey, patient, what do you feel comfortable with? Do you feel like you'd benefit from being part of a group therapy session? Do you want to do more individual therapy with this? It's important to talk to your client about what they're thinking and feeling about where they want to go with their goals first, instead of getting really scared about all the what ifs that can happen with trans individuals not perfectly fitting into a lot of our care systems. A lot of times, trans folks, despite some of the internet conversations about this, trans people really know that healthcare isn't set up for them. They know a lot of our culture and society doesn't have places for them, and they constantly have to compromise that. They understand that. So it's important to talk to your patients about where they are and what they want. It's important to partner with your clients, especially your trans clients, because they tend to know the score. They tend to know that there's going to be limitations on their care in some way. So make sure you're talking to them as opposed to getting super worried about all the what if scenarios or where they might or might not belong or some of the risk factors they might have. Just talk to them. The last one I feel is important, and this was created by the Office of Victims of Crime, the OVC. But this was also part of Forge Institute, if I'm not mistaken, and I want to say that's a Wisconsin-based institute for research. I could be wrong about some of that. I haven't looked into the details for a couple of years, but I think it's Midwestern is all I want to say. Like, that's what I want to say, because I think this fifth one, manage your curiosity, is just talking to a Midwestern audience more than anything else. Because I feel like we are so nosy. Like, just as a people, we are very nosy and we like to ask questions we don't necessarily need to. And I see this not even in the clinic. I see this like in the grocery store. And I heard a woman talking to another woman in like the frozen food aisle about her divorce. I'm just like, is this where we're talking about that? Is this an appropriate time to bring up your divorce question next to frozen food? And I feel like that's just how we are. Like we're just kind of nosy. And this is really related to that second one, know why you're asking, explain why, but it's even bigger. Because I think with queer populations, doctors who aren't experienced with, let's say, trans men, non-binary population, pansexual, like all these different identities, you get into this idea that, okay, my patient, this is my first pansexual patient. Let me ask them questions about what their sexual health is like and sexual practices so I know how pansexual patients work. There are a lot of doctors who do that not for malicious intent, but it really puts people on the spot to provide information they may not be comfortable with or may not have. And it kind of goes back to be able to explain why you're asking a question. But if you really need information about the culture of a community or the data or the practices, you can find that without grilling a patient. And patients might want to tell you that information, like they might start those conversations with you, and it's appropriate to follow those up. And they'd be like, this is this for me or that for me. And you can be like, okay, cool, that's really interesting. How else does that work? And if they're leading that conversation, you can have it. But make sure you're not making a patient your learning experience. There are people like me that can provide this education. There are a lot of different kind of books or ways to find data and research on this. Make sure that your patient isn't there to teach you, that you are there to treat your patient. So these are guidelines for that. And I think that if you follow through with them, you're probably going to be good with your care. The thing I really want to highlight here, though, is I work with hundreds of doctors like that are affirming in different levels and in different practices and different licensures all across the state. And if you or your team or wherever you are wants to be better about trans care, I can tell you the people who are fantastic at it right now, they're not fantastic because they listened to me for an hour. They're not fantastic because they took a 2-year course on it. They're fantastic because they cared and tried. And over time, you get better. And that's just what it is. You get more comfortable with asking questions about sexual history for someone who's lesbian. You get more comfortable understanding and talking to trans individuals and understanding kind of how hormones work for them and the levels of safety that are included there. The more you intentionally try to be better for this population, the better you will get. And if you spend the next 2 years just trying to make sure that you are safe for this population, you will become one of the best doctors in it. Like, I don't know if it'll be 2 years or 5 years or if you can achieve this in 2 weeks. But what I can promise you is everyone who's good at it now is good because they just started caring about it, trying to make places safe, and they got better over time. A lot of this is just experience. The more comfortable you get with it, the better you're going to be. And that's ultimately like the answers to some of these questions. So that's more of that one-on-one thing. But if we're looking at systems holistically and you're like, Faye, this is all great, but how do I just deal with everything? If you want to deal with everything, I recommend going to the Health Equity Index provided by the Human Rights Campaign. It is a guideline. It is, you go down there and it is, do you have this policy? Do you have this policy? Is your environment like this? And it is just an easy way to look at your entire system and see how you're doing in a really quantitative way. There's a lot of things that we can't easily measure, but if you're looking at just a really easy way to test your systems, to test how things work from the top down, I can't recommend this enough. And there are entities in North Dakota that have basically gone through to get things like this approved. Sanford and Bismarck, I want to say, is one of them. So some of our larger healthcare entities are basically trying to, get a 100% score in these, and it's something that's possible to do. So you don't have to reinvent the wheel. You don't have to sit down for a year-long discussion about improving processes. You can really just look at this health equality index, and that can be your goals to achieve. I think that for this presentation, that's kind of what I have when we're talking about demographics, outcomes of that demographics, and then ways that hospitals can respond to them both within our actual meetings with the doctors or nurses, and then the systems as a whole. So I'm going to invite some Q&A right now. If anyone wants to type anything in the chat or unmute themselves to ask any questions, we can do so now. And if not, I have at least one more thing to talk about. So I will just kind of open the floor to questions for the next couple of minutes and see what happens.
Hey, how do you challenge providers who essentially say they're sticking to the way that they practice as a matter of conscience or religious belief, et cetera?
That's kind of the whole spiel I had earlier about, you know,
And I missed that one.
tie it to their healthcare goals in some way. And there's two things to educate on that. And one is, that tying piece, like have a conversation about what our goals are and what our outcomes for the patients are. The other piece to that is there's research that we do with vaccine hesitancy that I think is actually really important when we're looking at cultural biases, because in a lot of ways, the foundation of that's the same. And what we find in that research, I was part of this like a few months ago, and I found the presentation just incredibly enlightening. But we tend to have a writing response to folks who have vaccine hesitancy or are not great with LGBT plus cultural things. And it's like, well, you need to do this because you're impacting suicidality. You need to do this because you're impacting patient outcomes. You're making folks not want to come to us, and you're hurting our healthcare goals. We are correct to say that, but that does not educate someone, and that does not help them actually learn or, become better in care. What has to happen for education for people to actually kind of, let's say, grow into better understandings of these things is you really just have to talk to them. Ask them, where is this coming from? What are your concerns? And what are ways that we can mitigate this? And the education on vaccine hesitancy is really good, but it's basically like, you kind of end the conversation with like, what would need to happen for, you to think about these things differently. Like you challenge them to come up with their own arguments for why they should be better about these things, and that can go pretty far. One thing that I'll say here is that I would say when I first started doing this work, I'd be like, well, if someone's not great with queer populations, get them out of the building. And I mean, there's a lot to that, but North Dakota has a lot of struggles right now with retention. And there are doctors who aren't great at queer populations, but we need them for everyone else they serve. So I look at this from a harm reduction lens. If we really need to just like make sure queer people don't go to that doctor, that's maybe what we do.
Right.
But I would say keep the dialogue open and try to be as understanding as you can in it, and just find where that harm reduction lens can be. So it's a tough conversation, but that's pretty much what you can do about it right now.
It's kind of motivational interviewing. Yeah.
Yeah, pretty much. And make sure they feel like they're not being motivated.
Right. Yeah.
I love when therapists practice therapy on other therapists, and like it's just
Oh, yeah. Yeah.
it's pretty
Absolutely.
funny. That's a good question though, and that's how we would approach it. I just kind of tied values, harm reduction, and then getting what you can out of those systems. Any other questions that we have at the moment? You can type them in the chat or you can unmute yourself. One thing I didn't cover, and I'd like to just kind of before we end it, I just realized this now. I don't know why it wasn't in there. Intake's a really important thing that I didn't cover. And the best way to do intake is basically ask, I guess there's a few ways to do this, but if it's a new patient, ask for them to spell their legal first name and last name. That way they don't actually have to say whatever their name is if they don't prefer to say it. Also, people's names are terribly hard to spell, so I have to ask that regardless anyways, and it's just better patient process. When doing patient verification, you can use, last name, date of birth, address. You don't actually have to use first name for that necessarily, whatever identifying information you need. And then even when talking to the patient, we try to avoid using first name in general because my clinic has so many trans folks that we're likely to misname them. So there are a lot of practices you can implement that make sure that you're less likely to be stressful for a trans person. And even it can be helpful for cisgender patients too, because not everyone likes their first name. Not everyone likes to be called by it. They might have nicknames. So when we're thinking about patient intake, a lot of times it's thinking about it in that capacity. I have shared my email in the chat. Anyone is welcome to email me. This is recorded, so I think you can rewatch it, but you're also, the slides are just, Prezi has not been treating my slides well. So you are welcome to message me for a link. And this is why I love Prezi. I can go here into demographics and I can look at the demographic data if I want to. That's not part of my presentation today, but it's there. I also have these resources I can get into, which isn't technically part of my presentation, but I have every affirming provider on the Harbor Health Initiative website that has signed up for it. There's a lot to say about that I can't right now, but basically it's a harm reductive model. How do we make sure we can get people in to actually be seen? I also have ways for trans youth to get care. I have all the data I talk about, I try to make accessible because I want patient outcomes to improve. I don't have to be the name behind the data. I just want that to be out there. I also work with secondary trauma quite often because we don't in this state, and we need to take care of our providers because if we don't, they're going to burn out and we're not going to reach our goals. And then I have a resource list together for basically all the essential information you need for queer populations. And that's like our 988 number for suicide prevention, affirming healthcare directory. This is something you can print out and have in a lobby or hand out to patients. So I do this work for the rest of my life. If you don't connect with me with my next training, that's completely fine, but you're always welcome to email me out, to send my email to other people. Any way I can improve North Dakota, that's what I'll be doing for as long as I can. So I just want to thank you all for coming here and participating and learning from this. And I'm your advocate. Any way I can support you going forward, I will do so. So thank you.
Thanks, Faye. That was a great presentation. And just as a reminder, I will send out the evaluation and the slides in an email following the presentation too, so you'll have it again. But thanks so much, Faye. That was a great presentation. We look forward to the next one next month.
Awesome. You all have a great rest of your day.
Thank you.